Our third presentation is by the same presenter, Daniele Corlazzoli, an ECVN Diplomate practicing in Rome, and he will now give us an update on spinal meningiomas. Thank you so much for being here.
Thank you. So we all know the theory, and we are quite late, so we know tumor, spinal tumor, extradural, intradural, extradural, okay? It's a matter of point of view. If you are a surgeon, if you are a pathologist, if you are a radiologist, that's the change. So, in particular, what really concerns me in diagnostic imaging is the difference between what is truth and what is true, and how true look like in the diagnostic imaging. Because when you are a surgeon, you are the last step of the decision, and you need to take a decision based on what everybody told you before you. So that's the critical point. So for a pathologist, a spinal cord tumor is what it says on the slide. For a radiologist, it's a list of differential. Well, I understand that from a radiologist's point of view, medicine is about defensive medicine, but it's not helping surgeon having a list of 10 nasty tumor when you're facing your surgical decision, especially because nobody will know ever what the final diagnosis is. And if you're a surgeon, here we have Dr. Harvey Cushing working on a brain surgery, one of the first brain surgery, early 20th century. From a surgical point of view, the issue is completely different, I think, because as a surgeon, our point of view is surgery an appropriate treatment option? Is it intradural or extradural? Is there another way to get to a diagnosis? Because maybe the dog has a lymphoma and you can make a diagnosis with an abdominal ultrasound. Can I remove it? What will be the benefit for the patient? What are the risks? What instruments do I need? And will I understand where to stop before you cause more damage than the disease itself? So let's start from literature again. Spinal meningioma, most common spinal tumor in dog and cat. In dog, usually cervical and lumbar. In man, usually thoracolumbar. In man's, the behavior is a little bit more benign than in dogs. Is not the cause in cranial meningioma. So you will be very sorry if you try to deal with this pathology thinking that it is similar to a feline meningioma. It is not. It arises from arachnoid capsule cells in the meninges that are frequent in the thoracic area human being. So we assume that this is frequently present in cervical and lower area dogs, but we don't have no yet. WHO 3 grade, 15 subtypes to classify those meningioma, and safe maximal surgical resection is the preferred treatment for spinal meningioma in men. We have 67 studies, including more than 3,000 cases reported in humans, but if we go to our field, we have 3 studies, including 100 cases, with only 32 patients operated and followed for more than 3 months, from 2008 to 2024, so not much to say. If we briefly review those papers, the more recently, 2018 Vet Oncology for patient surgery, to patient surgery and radiation. One died immediate postoperative euthanasia in the first 3 months, either because of failure to improve or complication. 3 lost to follow-up. 1 alive but tetraplegic. Is it a success or a failure or a recurrence? 6 patients, median survival, 700 days. The 2 patients treated surgical per radiation at the recurrence down the road around 400 days, and 3 out of 16 died of unrelated causes. Recurrences, so 4 out of 14, 3 then treated with radiation. Among those 3 patients, 1 survived additional 200 days and 1 is alive 1,000 and some days. Another paper, 2013, 8 patients, 6 treated, relapses 100% of patients. So this is not the cause of spinal meningioma or cranial meningioma in cats. 1 patient reoperated after 1 year and living for close to 2 years. Last paper, so how many patients? 24. 6 died or euthanized intraoperatively. Mostly patients with cervical lesion, because you understand that operating on C1, C2 spinal meningioma carries an high risk of complication in terms of bleeding and respiratory complication. 10 patients surgery with no radiation. They almost all had a recurrence. The 7 who had the radiation in top of surgery. 1 was alive at 41 months. 3 patients recurrence in between 18 and 36 months, and through that of unrelated causes 3 or more years down the road. So we could say probably, based on 12 patients, that some patients can survive years after surgery, but with a high rate of perioperative euthanasia, high rate of recurrences, and probably there is a role for post-surgical radiation or for radiation in recurrences, and probably we should also consider reoperation in recurrences. But there is a bias related to the small sample because there are so many factors involved. So how many months the dog has been symptomatic before surgery? Because some dogs go to surgery after 2 months of clinical signs, some other 10 months down the road. How profound were the clinical signs of presentation? Was it plegic or was it working with pain? Where was the lesion? Was it accessible or not? What was the size of the lesion? The invasiveness, the amount of resection, was it gross total resection or a subtotal resection? What was the grade? What surgical technique? Because till the recent book was published on neurosurgery and veterinary medicine, and there is no indication concerning the need for microsurgery, microscope, CUSA aspirator or something. And because we don't know how many dogs had positive radiation. But the general scenario is a patient with progressive clinical sign, partially responsive to steroids. In this paper, about 53 dogs diagnosed with necropsy, they state that the median survival time was 20 days, so not much to wait for, okay, in most patients, even if some dogs can live up to 200 days. And I would add to discuss also about other lesions. So what if it looks like a meningioma, but it's not a meningioma? Because as we said, MRI is not that efficient in telling you what is it. If we go back again to this paper, we could say that 20 out of 31 were potentially treatable spinal cord tumor if you rule out metastatic lesion, because of 13 ependymoma, 4 nephroblastomoma, 2 hemangioblastomoma, 1 teratoma, so something that looked like a meningioma, but is something different that might carry a different prognosis. So not much to base our surgical treatment on. So I was assigned 40 minutes, so I thought to myself, maybe it's more helpful, more stimulating if we discuss just about real clinical cases. So why don't we take a walk in real clinical cases to see if these are more inspiring to us than just numbers. So I could operated, well, almost 27 cases in this 14 years period. And beside meningioma, there was a list of other things that could be neoplastic or non-neoplastic. And I can tell you that it's very difficult to predict which one is which. And I will see those cases. So this is a classic one. Snoopy, German Shepherd, German short hair pointer, 10 years old. What I would call a classical presentation for a meningioma with a dural tail. It's very important that we understand what are the pillars of microsurgery in human neurosurgery, because it's time to step away from what I call the surgery of the 70s. We need to understand how they perform surgery and try to understand how to improve ourselves, to understand that you need to have a bloodless field, you need to use cottonoid, the 2 strips on the side, you need to use tag suture, you need to use a microscope in order to do the surgery. You need to cauterize the dura mater because those are vascularized tumor, and if you don't do it, then your surgical field is going to be a lake of blood. You need to cauterize on the tumor, of course, washing it to avoid heat problem, but if you do not cauterize the tumor surface, then again you will have blood all over the place. Then you can look for a cleavage plane, either with a bipolar tips, not with bipolar current, of course, or with microsurgical. And you need to inspect the surgical bed for remnants, because those small pieces on the spinal cord will be where the tumor will regrow from. And so if you send to the pathologist these small pieces, he will tell you that probably it is either arachnoid, if you are in the good safe, or meningioma parts. Alive 1 year post-op, MRI negative. Let's see a similar case. The referring vet did the CT before checking for meds, and you see that the clinic picture is pretty much the same. Much more blood coming from the epidural space, so we had to place a cottonoid in the epidural space. We had also to increase the exposure, because sometimes you measure the meningioma, you think that you made the right windows, then you do the durotomy and you find that the meningioma is crossing under the bone, so you need to see the spinal cord, you see the white under the durotomy. This is where the tumor ends. And then again, cauterization of the tumor. And we place a piece of collagen in the epidural space because the cotonite was not enough, it was oozing blood again. Then we could find a cleavage plane, it was not adherent to the spinal cord, and we cut off a strip of dura with tumor up to the normal dura, both dorsally and ventrally. Hemostasis is one of the pillars of this surgery, and we used here a tabotam fragment in the two parts. You could also use a bipolar with very low settings and irrigation, of course, but depending on you. You did the surgery, you remove the cotonoid, but sometimes it's not your day, so you need to do something more. You place back some piece of collagen, not enough, so you have to place again some tabotam. There is a lot of discussion on the neuro field if you should leave or not something behind, but I can tell you that you cannot leave a bleeding open in this way. You cannot wait 10 days with the surgical table just to wait for the blood to stop. Because when you close it, you need to be dry. Otherwise, you're going to bleed against the spinal cord. I always put a dural substitute, and I always put a drain, a Jackson Pratt drain, because I've been sorry too many times not doing it. Because if it bleeds, then it's going to have complication. Spinal meningioma recurs 15 months down the road. We advised the owner for radiation, but it didn't went for because of the cost, because of course this is going to double the cost of the procedure. Fulmine, 14 years old, cervical. Again, when you head to the right, spine to the left, when you do a C1, C2 dorsal laminectomy, you frequently find a dorsal ligament that can be adherent to the dura mater. You need to cut it with leaven blade, or sometimes you need to dissect it with micro scissor, and you need to tag it with a suture. Whenever you do a tumor, whether it is a brain tumor, spinal cord tumor, I think, my point of view, you should always see the entire lesion, because you will never be able to reach the tumor that is behind the bone. So before starting incising the dura, you need to see the full tumor. Again, similar, we have tag suture in the ligament. The tumor is apparent after the durotomy. After bipolar coagulation, take a sample before it's too late, because you need to give your pathologist something to comment on. And sometimes you are so focused on the lesion that you don't have time to do it. You can also use a cruise aspirator. This is an ultrasonic aspirator for some lesion. Can be very helpful. And you need to extend your dissection to remove all the dura involved in the lesion that sometimes reveal a further part of the tumor. And again, tabotam left in place, because tabotam is better than an hemorrhage in a post-surgical patient. Alive 2 years post-op, WHO grade 2. Lady, a similar lesion, but when you see a soft tumor, that's good for you, but bad for the patient, because it's very easy for the surgeon to remove soft tumors, but it's very easy for the patient to have a recurrence, because the tumor infiltrates all the surgical field. Again, you see soft tumor, but you need to remove all the dura involved that sometimes can show other parts of the tumor, like you see there. So as much dura should be involved as possible. Hemostasis is not easy in the cervical cranial area. You can see I had to use a clip, because there is a vessel that Professor Vicente Aige nicely identified as a venous structure that link the ventral sinuses to the transverse sinus, that is through the basilar sinus. And this large sinus cross on the lateral surface of the spine, of the spinal cord. So when you remove the dura, you frequently find it, and it bleeds really massively. Pete, mixed breed, 3 years old, quite a nice suspect of meningioma. Identify the lesion, cauterize it, remove it. Good day for surgery, but 2 days later, the dog got worse. They got tetraplegic because of bleeding on the wound. We went back to surgery, This is there was a large coagulus in the muscle plane. We removed the dural substitute, and the blood in between the spinal cord and the dural substitute. So the bleeding was mainly on the muscle planes, and that's why we started using Jackson Pratt routinely. And we removed also the collagen on the ventral surface just for safety. Just we removed and replaced it. Spinal meningioma again. Fritz, mixed breed, 9 years old, ventral lesion. Only SCT was available. We did the ventral approach. We got to the dural aspect. We incised the dura with the bevel of a 1 millimeter syringe. It is a very sharp and fine. It's very helpful in this situation. We removed piecemeal the lesion with biopsy forces because CUSA was not available in this time in the clinic. And again, step by step, coagulation, and very carefully get to the spinal cord. And you can check for the resection we did. Of course, this is not a wide gross total resection like you expect in a soft tissue tumor. And stabilization afterwards. Dog went well, had a recurrence 1 year later. Birba, feline, ventral lesion. Well, we did surgery because, as a surgeon, sometimes you think you're invincible, but sometimes you just can't. And the lesion was tenaciously adherent to spinal cord, so I was hoping for a soft tumor to maybe aspirate out, but it was not possible, so I just took a biopsy in this patient, and the patient was euthanized. So we are not always successful with surgery, of course. Leo Britton, quite a lovely lesion, nice lesion. This is how reddish and vascularized look the lesion before you cauterize it, and that is how it looks when you devascularize it. If you start removing when it's so vascularized, you're gonna create a mess. You will not be able to complete the surgery in a good way. We removed the lesion piecemeal. Probably CUSA would be a better option for this patient. And you see that is not really something belonging to the dura mater, because we all think that the meningiomas arise from the meninges and from the dura mater, but sometimes it arises from the deeper layer of the meninges, so that it sticks to the spinal cord as if it was a spinal cord tumor. I don't think you can do such a dissection with naked eye or with loops. I don't think so. And you get to the final removal of the lesion. Okay. Meningeal. 6 years later, the dog had a disc extrusion, and they did a recheck MRI at the recurrence, but was without clinical signs. So we decided to wait and see what happened, because the dog was asymptomatic at the time. But 1 year later, it came back hemipharetic and painful. So we had to go back in surgery, where we found a catastrophic amount of fibrous tissue, scar tissue, very difficult to incise through. But finally, we could get to the lesion. And we decided to remove it with CUSA aspirator. Need to be very careful because CUSA aspirator doesn't distinguish between spinal cord and tumor. So you need to be more careful than And we need to remove also the dura mater on the floor. And of course, when you cut through the dura mater on the floor, you expect bleeding. And we'll have to manage the bleeding afterwards. How do you manage it? Again, tabotam, collagen, bipolar. But when you close, you need to have a dry field, otherwise you're going to be in trouble afterwards. MRIs give you images in a grayscale, but in reality, lesions are completely different one from each other. So maybe something that looks like a meningioma is not indeed a meningioma. This is what was it? Siberian husky, 2 years old, with the lesion, reddish lesion. You start always by bipolar cauterization to create a cleavage plane, because you need to cauterize the arachnoid first and then to find a way to dissect it away from the spinal cord. And you can then proceed like we saw in the first cases. Spinal nephoblastoma recurs 14 months down the road. Bia, feline, what is it? Try to guess from the MRI what would be the histopathology diagnosis at the end. We have just a few cases. You would expect probably meningioma. but the spinal cord is normal in appearance. It's probably a little bit swollen and discolored on the left side. And we did a biopsy of a soft lesion that turned out to be astrocytoma. Even if it was assumed that astrocytoma do not acquire a lot of contrast, that's the theory behind it. Another cat, high contrast uptake, again, spinal cord normal, no meningioma around. We did the biopsy, B-cell lymphoma, euthanasia because the cat was too compromised. Bingo, I lost the MRI of this patient, but it's so important for my path in this disease and for your understanding that I want to present you for a human with the same lesion. So this is a human being with the same lesion that Bingo had. This is a C71 lesion behind the rootlets, and I want to show you this video because it's the way you should not do spinal cord surgery anymore. Because there is no reason for removing a mass in a hole. You should always remove a mass piecemeal or with ultrasonic aspirator. That's a catastrophic mistake we have in our literature. We should not remove lump in a single movement, neither in the brain nor in the spinal cord. That's something I learned from our human counterpart, and it should not work in one such a bleeding, because if I would have cauterized the surface of the tumor, you would have seen a clean surgical field. And I was just lucky enough that the tumor was not adherent to the spinal cord, because if you place this amount of traction on a spinal cord, you will cause a severe lesion. So don't account on luckiness for plain surgery. Hemangioblastoma, alive 2 years post-op. I'm so proud of this dog because with such a nasty name, I would never expect a 2 years follow-up. But indeed, this is a tumor with a good prognosis in dog and cat, in dog and man as well. Golden Retriever, 2 lesions in the spinal cord. I thought maybe this was the ependymoma I was looking for years. Normal spinal cord appearance. You cauterize the pia and you gently dissect it through the spinal cord, but the lesion was not cleavable, so we could only take a biopsy of it because there was not a cleavage plan. The lesion was infiltrating. So you could see the white bottom of the lesion, but you cannot remove the lesion. Final diagnosis, intramedullary neuroblastoma, euthanasia. Another very important patient to me, a Dachshund, 3 years old, that came after a long trip back to our clinic. I'm sorry for the images, but those are just very old cases. And again, you see the lesion, you see a black lesion, so we think maybe this is a nasty melanoma, or maybe this is a vascular lesion, I don't know what this is. I will try to remove it. I don't suffer Parkinson's, I will explain then why there was such a tremor. But you need first to cauterize the arachnoid to start the dissection. And my error is that I try to remember myself that when I have surgery on a microscope, I don't drink normal coffee, I get the one without caffeine. But sometimes I'm sleeping in the morning, I just mess up the bottles. And this was one of the days I should have drank the caffeine, the coffee without caffeine. Anyway, you look for your dissection plane. Or again with the bevel of a needle, but at the end you can find your way, respecting the spinal cord and removing the full amount of lesion. You check, again, never aspirate against the spinal cord directly, but always use a small piece of cottonoid, otherwise you're going to suck the spinal cord out. Final diagnosis, mixed epithelial and mesenchymal cyst. So this was a broadly progressive clinical sign for months before surgery and lived enough to have 2 disc extrusions down the road and died of elderly. Tia, Newfoundland, 2 years old. Again, no one will be able to comment on this MRI in this room. I'm not able neither, and radiologists neither can comment on those MRIs, I think, because that can be whatever. The final diagnosis, whatever. But dog was paraplegic, 2 years old, so we decided to go to surgery. That's the appearance of the lesion. Again, technique repeats itself. Always take a biopsy before it's too late, because maybe the lesion is too soft, and maybe then your pathologist cannot give you an answer. But this was a very soft and easy lesion to remove, so easy to clear the lesion out. Final diagnosis: necrohemorrhagic vascular anomaly. The hemorrhage and the necrosis prevented further details on the technique. But this is related to this paper that is so important for this topic, because it states that MRI cannot be used to distinguish neoplastic from non-neoplastic lesion. So we have too much faith in what our radiologist told us, and we need to assume to take our decision ourselves. This was the case in the paper, and had a good resolution. Probably was less severe than my Newfoundland, who just moved from paraplegic to paraplegic, but arrived after a very long history. We are almost done. Tiago, mixed breed, 1-year-old, paraplegic, 30 kicks. Again, want to comment on this MRI? I will not. I can only comment on the fact that I'm facing a paraplegic dog with a focal lesion, and his only way to get back to normal is if we both are lucky enough to have a surgical condition there. Again, find a cleavage plane, increase it, place a cottonoid to keep the dissection open. This was evident it was a fluid-filled lesion, so probably I should have been aspirate the content and progress on the removal. Probably would have been more elegant, but sometimes we make errors. So, and we keep on removing. Much easier to remove it after it collapses, of course, but I was not smart enough that day to think about that. Very mild adhesion, but what you see on the bottom was again part of the lesion. So we removed again small fragments, and again the same histological characteristic of the lesion. So pay attention to what's happening in front. We always close the dura whenever it's not involved in the lesion. This is again something I learned from a human neurosurgeon. Even if I know we don't have a CSF fistula, but if a spinal flow is relevant for our patient in so many diseases, it should be relevant also for this patient. Neuroenteric cyst. Have you ever seen neuroenteric cyst? Probably not. Probably it's 2 cases in one lifetime, but it's 2 cases that would have been gone to neuropathology directly from necropsy table. One last case is Stella Labrador, 3 months old, belonging to a referring vet, progressive clinical sign, 3 months. What is there? Reddish lesion. Just same procedure. I mean, it's a surgical technique you master, then you use in several cases. Probably I could have been more delicate in this case, but again we close the dura. These, all very old cases. Myelitis, mixed leucopolio. So as a neurologist, we think that lesions are gliomas, thrombocytoma, meningioma, or lymphoma, and myelitis are always unknown origin, immune-mediated. There is a lot of different phenotypes of inflammatory lesion and tumoral lesion. The dog is still running and jumping 12 years. This summer, the colleague sent me the video. Would he have been alive after diagnosis of spinal cord tumor and 3 months and progressive clinical signs at 3 months? Of course, the gait is not a perfect gait, but I wonder how many veterinarians would have put to sleep this dog just because the MRI was suggesting a spinal cord lesion, tumoral lesion. Last case, I promise this is the last case. Emma Cocker, 6-year-old, white lesion in spinal cord. Maybe looks kind of round on the transverse. Maybe the fact that acquires so much contrast on CT brings you more to the tumoral suspicion. Dissection through the middle, midline myelotomy. Not something you really do very confident, but you have to do it if the spinal cord is looking normal. You look inside the spinal cord, everything is white as snow. So you check 4 times with the fluoro, you check 4 times with the radiology department, want to know if it is related L1 or maybe somebody mixed up with the report. Nothing in the spinal cord beside the contrast uptake. Not a very good feeling this morning. So I decided to take a biopsy because I think only pathologists can tell you what is going on there. And the final diagnosis was myelitis reconstruction. Yes, we didn't do a CSF tap because the dog was investigated at another clinic and they thought about an neoplastic lesion, so CSF was not planned. And when we saw the dog was already under steroid, so you know the theory, we do not do CSF. And probably this would have brought us to diagnosis without surgery. Dog is doing well beside the dorsal myelotomy and the biopsy is Emma a few weeks down the road with physical therapy. It was just hemiparetic after surgery. So MRI will not help you distinguish neoplastic and non-neoplastic lesion. And a large intradural lesion is difficult to differentiate from intramedullary lesion, so do not expect MRI to tell you which patient you should go to surgery and which one not. But most spinal cord lesion can be potentially treatable because of the ependymoma, that is a potentially treatable lesion, nephroblastoma, meningioma, angioblastoma, teratoma. The list will be longer and longer the more we do this surgery. And let's give a chance to this patient because intradural lesion can be whatever, can be operable, could be non-neoplastic. Hemostasis is crucial, so if you go in for this surgery, you need to master this technique. And I can tell you, no microscope, no surgery, no way. Just time to step away from the naked eye surgery for, in general, neurosurgery in dogs and cats. Knowing is not enough, we must apply. Willing is not enough, we must do. That's quite a relevant statement. Let's apply to this topic, I say. Thank you.